all these nicely presented videos. This topic seems very much out of place. So around 5 years back, alcoholic hepatitis was a topic which was entirely in physician's domain. So these patients, they were managed by gastroenterologists or hepatologists. But now slowly, this has come. This has become one of the important indication for liver transplant. So a purely transplant-based topic. So we know that, I'll rush through the slides. So we know that alcohol is one of the leading cause of preventable liver-related morbidity and mortality. We now see most of the patients who come to us for liver transplant are either non-alcoholic fatty liver disease or alcohol-associated liver disease. And this spectrum ranges from asymptomatic to steatosis, to steatohepatitis, to cirrhosis. And alcoholic hepatitis is seen in approximately 20% of people with alcohol use disorder. So alcoholic hepatitis is a clinical syndrome, and there is a distinct histopathological correlate which is known as alcoholic steatohepatitis. And underlying cirrhosis is present in nearly 40% of these patients. So the diagnosis is purely clinical. Onset of jaundice within early onset of jaundice, ongoing consumption of alcohol, rise in liver enzymes, and increased total bilirubin. And there are three entities which, like possible alcoholic hepatitis, probable hepatitis, or definite. So definite is when you get a histopathological confirmation that is definite alcoholic hepatitis. So there are many prognostic scores that are used for this, for the diagnosis and for prognostication, but then the three are most common. One is MDA for Madry's discriminant function. With I'll just summarize that patients with a MDF score of 32, they are classified as severe hepatitis. And why this is important? Because these are the patients that are offered steroid therapy if no contraindicating factors like infection or GI bleeding is present. Then another is the Lilly's score, which evaluates prognosis after you give steroids to the patient after 7 days of treatment. And patient with Lilly scores above 0.45, they will not benefit with corticosteroid, and they have a very bad survival. MELD score, we all know that this is the best prognostic indicator, and severe alcoholic hepatitis is diagnosed when the MELD score is more than 20. So why is alcoholic hepatitis important? Because these patients, they are continuously drinking alcohol. Sometimes a patient with alcoholic hepatitis will come to your clinic when he is still drunk. So these patients, they have a very high mortality, around 50% in the first month, 6-month mortality of 70%, and 1-year mortality of 90%, the highest with all liver diseases. And majority of deaths occur within 1 to 2 months. So there are many medical therapy options that have been described, but but no pharmacologic therapy shows long-term mortality benefit. The only recommended option is corticosteroids. So this is a chart that shows all the treatment options that have been tried for these patients. But as I said, only recommended therapy is steroid, and that is also for short-term benefit. So what is the problem in doing liver transplant for these patients? These are sick patients. They have got a liver disease, then why are we not transplanting them? So the reason is there are arguments against liver transplant for alcoholic hepatitis. We are going to transplant liver to a patient who is continuously drinking, and there is no period of abstinence for that patient. Then there comes the issue of equity in liver graft allocation. Because alcohol dependence is a self-inflicted disease. The society feels that this is a self-inflicted disease which patient has brought upon himself. And there are high chances of alcohol relapse leading to graft loss and futility. But then now the arguments have come up in favor of liver transplant for alcoholic hepatitis. These patients, they have raised a MELD score. They fulfill the basic criteria for listing, very high mortality. So they need to be saved. And other diseases which cause other chronic liver diseases, they can also be considered as self-inflicting, like hepatitis B or C, high risk, which occurs due to high risk behavior of the patient, or non-alcoholic fatty liver disease, which occurs due to high caloric intake in obese individuals, or acute liver failure which occurs due to suicide injury, due to ingestion of poisons, etc. They can be considered self-inflicting disease. Then why is alcohol different from all these diseases? So based on these, it can be said that you can give similar benefit of doubt to these patients with alcoholic hepatitis. So as I said, alcohol use disorder is now no longer viewed as a result of moral weakness or self-destructive behavior. So it is a type of chemical dependence with neurobiological roots. And despite best of the pre-transplant abstinence, even if you transplant patient after a 6 month or a 1 year abstinent, alcohol remains a lifelong chronic relapsing condition. So rather than totally refusing these patients a transplant, the post-transplant care should focus on lifelong de-addiction. So what I will be talking about is early liver transplant for severe alcoholic hepatitis. What should be the selection criteria for these patients? Severe alcoholic hepatitis, as I said, MDF score more than 32, MELD score more than 20, non-responsive to medical therapy, first hepatic decompensating event. So the patient should have an insight to disease process, and there should be absence of coexisting psychiatric disorders like depression, and there should be a family commitment. So if patients who come within the category of severe alcoholic hepatitis, they do not benefit from medical conditions, that they can be offered liver transplant. So this was the landmark French-Belgian trial which happened in 2011, and this changed the course of these patients. It was a multicentric prospective study, 7 centers, 26 patients. All were biopsy proven alcoholic hepatitis, and their data showed that patients who received liver transplant had a 6-month survival rate of 77%. Otherwise, the 6-month mortality is nearly 70%. No alcohol relapse in initial 6 months. Only 3 patients relapsed, that too at 24 months and 37 months. So this trial challenged the 6-month abstinent rule for liver transplant in alcoholic liver disease. And after this trial, the number of centers that started performing early LT for severe hepatitis increased manyfold. Now then came the Accelerate AH trial. So this was early liver transplant for patients with severe alcoholic hepatitis. Largest observational study, 147 patients. All were severe alcoholic hepatitis. And thus, after post-transplant survival at 1 year was 94%, 3 year was 84%, which is way better than if these patients were left alone or if these patients wait for 6 months abstinence. And post-discharge, after around 75% patients remained abstinent. This meta-analysis was done in 2018, and again it shows the same result. So all of these studies, they are showing the same result, that if these patients were offered liver transplant without abstinence, then even in these patients we get a good survival rate. This is again a 2022 study, quick trans study, early liver transplant for severe alcoholic hepatitis. In this study, this was a prospective study. There were 3 groups of patients. One patients with severe alcoholic hepatitis who underwent early liver transplant. Second group was where 6-month abstinent was seen, and third who were not eligible for liver transplant. And the result was amazing. 2-year survival was 90%, and which was similar to the standard liver transplant group. And this was a markedly different survival between the early liver transplant and not eligible for liver transplant group. You can see there is a marked difference between the 2 groups. So even contrary to our belief, if these patients who are still drinking and these were offered liver transplant, then they will start drinking again. Alcohol relapse was seen only in 34% of patients. And there was no difference between these patients and the controls. So again, this is world's largest series of liver transplant for severe alcoholic hepatitis. Again, similar type of results. No difference in patient survival, graft survival between these severe alcoholic hepatitis patients and the standard patients. And 6 month survival was around 98%. So all these studies have now shown us the way that these are the patients who should be listed for liver transplant, who should be allowed liver transplant without an abstinent period. So to summarize, severe alcoholic hepatitis is a clinical syndrome with very high mortality, and corticosteroids are traditionally considered the first line medical therapy. And but now the literature has shown that a 6 month abstinence period should not be insisted upon while referring these patients for liver transplantation. And early liver transplant is the only therapeutic approach that reduces 6 month mortality in these patients from around 70% to 10%. Thank you, everyone.